Good morning, everyone. Thank you for joining PHCA for today's webinar, Transforming Dementia Care. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website later today. The webinar has been approved for one continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and to our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenters will address them throughout the presentation. Today's webinar is being presented by Jill Curtis, Education and Outreach Coordinator with the Greater Pennsylvania Chapter Alzheimer's Association, and Kellie Butsack, Associate Director of Programs with the Delaware Valley Chapter Alzheimer's Association. The Alzheimer's Association will be highlighting today their newly released Alzheimer's Association Dementia Care Practice Recommendations that outline quality care practices based on a comprehensive review of current evidence, best practices, and expert opinions designed for professional care providers. These recommendations will form and influence dementia care standards, training, practice, and policy from a person-centered focus. They will also help decipher and understand dementia-related behaviors and determine how best to respond through non-pharmacological approaches to care. I'll now turn the webinar over to Jill and Kellie.
Good morning, everyone. Thank you for that wonderful introduction. So let's go ahead and get started since we have a short period of time to get through all these good things. So basically, the Alzheimer's Association, as Wendy had mentioned, we've always been a leader in outlining principles and practices of quality care. Basically, what you can see here is from the 1980s, where we focused a lot on the Guides for Dignity. Then also into the mid-90s, some of you may be familiar with the key elements of dementia care. And then moving into the early 2000s, we had these dementia care practice recommendations. So we are always looking to improve ourselves, and the most recent publication was this in the Gerontologist, and this came out in 2018. And basically, as you can see, we again focused on evidence-based practices, and we really convened quite a few professionals in order to gather this data. And again, it's very thorough. It goes into 56 recommendations. Today, we're going to kind of concise this down a bit and make it a little bit more manageable within our 30-minute time frame. So again, one of the key pieces that you're going to see that most of you are very familiar with is that this is all focused on person-centered care, something that we've all been very familiar with over the years. And breaking it down, again, those 56 recommendations that were implemented are going to fall into this care of 8 different pieces. And we're going to highlight those this morning, basically starting with the first recommendation, again, person-centered focus, knowing that person. Knowing that person's reality. What we mean by that is trying to encourage no more reality orientation. I hope that we will move through that, and providers that are doing reality orientation will no longer be doing that, because we know now that we have to go where that person is. Meaningful engagement, purposeful engagement, again, those caring relationships, a good community, Supportive community and evaluation of care practices. Basically, we want folks to start realizing that we want to provide care with the person, not doing care for the person. And again, that's going to be a big change sometimes for folks. Moving into the first recommendation is our detection and diagnosis. And this is really where one of the first pillars of the Alzheimer's Association comes into play. And that is, we really want folks to know what they're dealing with as soon as possible. And way we can do that is, number one, to start talking about brain health and cognitive aging, talking about the need for good brain health through diet, through exercise, through social engagement, cognitive stimulation. And then also knowing what signs and symptoms are normal aging and what aren't normal aging. And again, being able to safely talk about that and bring that to the attention of their supervisors so that they can, better know that resident. Basically, let me look here. We're looking at the routine procedures. So having available, cognitive assessments, behavioral screenings, mood and personality screenings to kind of help us, again, better understand what the changes are that those individuals are going through. And again, helping families understand the importance of going to the next step for an appropriate diagnosis. And then therefore, when we do have a diagnosis, being able to understand exactly what that means. And again, for those resources are always available on our website, alz.org, which we will be talking about later on as well. But a lot of those toolkits are available online, even for you to be able to download and provide those to your, let's say, your attending physicians, your nurse practitioners, anyone that is in your facility that's competent and capable of administering those screenings. Moving into the next recommendation is that assessment and care planning, and realizing basically that we would prefer to see assessments happening every 6 months, just again, being able to anticipate decline, and also being able to have the team approach and having that team feel comfortable bringing those assessments and those changes to the light of the entire team. Looking at accessible documentation and communication systems. What we mean by that is, again, allowing even some of the direct care staff to be able to know what is going on, what is the type of dementia that this person's been diagnosed with, because that's going to be important as we see as they change and move through their aging process. Are we dealing with a true Alzheimer's, or are we dealing with a Lewy body, where we may have some different, behavioral and psychological symptoms that are going to impact how we care for them on a day-to-day basis. And then also looking at advanced planning. And again, this is not only going to include maybe moving through the care continuum, moving from personal care to, skilled, but also including palliative and hospice as we move. The next recommendation is how we medically manage our patients. And again, looking at the holistic person-centered approach, what is the role of the medical provider? And hoping that the medical provider can partner with the families and really help be that key point of understanding for them as they're moving through this. Knowing that those common comorbidities are going to impact the decline of the disease, and helping families be aware of that and prepping for that before there is an incident can also be a really big win as you're interacting with them. As you can see here, we have our non-pharmacological interventions, and that is exactly what the second half of this webinar is going to be consisting of. Kellie is going to highlight just how we can do that, because we all know what happens when we start adding medications to our folks with dementia. Planning for possible medical and social crisis. What I think we would like to accomplish with this is good handoffs between providers, when we're sending folks out to the hospital, when we're sending them just to regular medical routine appointments. You know, maybe we have to look at having a staff person that really knows that resident accompany them to those appointments, because that's the best practice for them. That's going to make that resident feel the most comfortable and safe, and eliminate some of those behaviors that we may see when they're out of their care community, out of their norm. And then also having those end-of-life care discussions before we need to do it, always planning ahead. So looking at the next recommendation is our information, education, and support. And again, I don't think we can talk enough about preparing for the future. And again, this all ties back in, as you can see, as we've been back to our very first recommendation. You know, we have to have the diagnosis. We have to know what we're dealing with in order to prepare for the future. We want to work together and plan together. We can't do this alone, and that's one of the things that the association starts, you know, really planting that seed in families early on, is who is your care team? And your care plan team doesn't necessarily just have to be healthcare professionals. You know, we may be looking at you know, our church families. We may be looking at some of the volunteers that come into your care community that really just have a connection with that person. We want to enhance our culturally sensitive programs, and there's so many benefits to that, because again, that also enhances a sense of confidence in your staff if they know, let's say, how to approach, you know, folks of different backgrounds. We also have lots of support for the LGBTQ community, and we can also help you with those situations as well, with those families. Looking kind of into technology, how that can help bridge that gap and that distance between families. We know that folks are all around the country now, you know, different parts of the world, and how can we connect them? And then also too, if we're using telemedication, and that may be helpful for some of us that are in the more rural areas. So moving on to our ADLs, again, a lot of these we know, but I think it's important to recognize that these are significant enough that these made the list, you know, for these recommendations. So supporting those ADLs, and again, like I had mentioned previously, when we are providing care, where we want to change that mentality of, instead of doing it for them, we want to do it with them. And that very well may be modeling that behavior, allowing staff to have that time of standing in front of the mirror with that patient and actually brushing their teeth together, so that they can still have that range of motion and that sense of self-purpose, that they can still do that. And just again, it's just us as providers being able to look at things just a little bit differently. It may take a little bit longer, but think about the social aspect of what that's doing for that patient, and also for that family to see that you've vested that time and allowing that change in care and approach between their staff and their family member. Again, choices. With dignity, and we're coming in, especially with dressing, with toileting, with eating. Being mindful, I think, too, of the changes as our loved ones are progressing through this disease. again, letting the families know that, okay, we're noticing a change in her ability to, tolerate different textures of the food, and allowing families to understand how that's going to change as the disease progresses, I think can also help ease that frustration between families and care providers. Moving into the next, we're talking about behavioral, BPSD, behavioral and psychological symptoms of dementia. And that's the fancy word of saying those behaviors that challenge us at times with our folks with Alzheimer's and dementia. Again, we know this is a huge issue, a huge topic, I should say. And that's why Kellie is going to be talking about this, the second half of our presentation today. But again, looking for triggers. Is it something that's happening in our care community? Is this happening? Is there a certain behavior that happens every time that the fire alarm goes off, or that there's a change in lighting, noise stimulations, those things? Really looking at how we can make changes by assessing, reassessing those behaviors and using those non-pharmacological practices. One of the things that the Alzheimer's Association is really looking for is to help you educate your staff and your team with the investment for implementation. And basically, we understand that these protocols may take time. It may take just again, some more buy-in from folks that maybe have had good success with non-pharmacological practices, and then allowing there to be new protocols. Have we tried this before we do this? And again, pulling in all members of the team when we are looking to evaluate the effectiveness of that intervention. And again, I'm not going to highlight this too much because Kellie is going to go into this. How these recommendations are going to impact the workforce. We are hoping that the association will be involved with each of you in some way as far as using these dementia care practice recommendations, and also having some curriculum coming down the pike early next year that will be able to give you these tools so that you can really enhance your workforce, being able to then incorporate this into all aspects of your training, not only with onboarding, but ongoing. Hopefully, these implementation of these types of systems and changes will help decrease staff turnover, will empower your staff to be able to make decisions and try those behavioral interventions on their own, anticipating some behaviors before they happen, because they're trained and they're confident and they know what they can do and how they can best approach that patient or that resident. Moving into the next is definitely the supportive and therapeutic environment. We want folks to know that they're going to be able to not have pain, not feel that there's restraints, again, be reminded that this is their home, and that everyone there is there for them. Again, highlighting those opportunities for choice. And again, that doesn't necessarily just mean food, clothing, but also what activities that they may want to participate in or not participate in. And I think sometimes we have to remember that not everyone wants to go down to the large group activity. Some folks, do better one-on-one. Just kind of, again, being cognizant of those changes and having that meaningful engagement. And this, again, goes back to, you can see how it's kind of like that circle that we were, that back a few pieces ago, we talked about assessment and sharing knowledge among different levels of staff. And that's how we're going to be able to best provide meaningful engagement for our folks, is by knowing them. So again, we also kind of highlighted a little bit of this in some of those other recommendations, but the transition and coordination of services. Again, helping families, helping the residents understand the different levels of care. You know, when are they going to be ready to move? Is there a change in your care community where, you know, if they are having a decline, are they going to be able to stay in that memory care unit, or will they be transitioned to the main nursing floor? And again, being able to be upfront with families and also with staff and preparing them for those changes if that's the way that your community works. And again, we're looking at the timely communication, again, not waiting until there's a decline or a crisis. Making sure that those preferences are handing off. You know, if you know what is going to make that person happier, please be able to share that, not only among shifts, but again, if they go to the hospital or if they're going out for an appointment that day. The next slide is really interesting, and I hope that you can go back and take a look at this when you have a little bit more time. But basically, in conjunction with these practice recommendations, the Alzheimer's Association developed a separate report that examines the quality of care through the eyes of people living with dementia. And these are some of the insights from folks you know, that are living with the disease, that have been diagnosed, and what their hopes are as they enter care communities and the continuation of care. And I think it's validating to see that the Alzheimer's Association and those dementia care practice recommendations were right on point with exactly what the folks are saying out there that are living with this disease. And again, this kind of wrapping things up for my portion, I think, again, the circle is a perfect example of that is a continuum, and how each of those kind of flow into each other, but all centered around our person. And basically, how are we going to put this all together? Well, one of the things we know is that this never happens all at once. So it's going to take time. And I encourage you to give yourself and your community time to make this work. So we're going to develop that plan first. What do you want to accomplish? And it may be a small step first. It may not be my whole staff is trained and comfortable with working with a patient with dementia. It may very well maybe you know, we're going to turn the volume down of the fire alarm because it always is causing behavioral issues. Or is it, you know, maybe we're not going to use so many restraints. We're going to start really working with nursing and see if we can work on that so that it's a safer environment mentally as well. And then creating those long and short-term goals. Again, knowing what is important, and can we do something in a short-term goal that's going to give us a win, that's going to help us build our confidence. Including the staff, and that's not just our direct care. We got to look at our maintenance. We've got to look at our dietary. We've even got to look at some of those persons that are coming in and out of our building to get input. And again, taking those small steps and you know, realizing this is not going to be an overnight change in your community. It truly is a culture change, and that takes time. If you need help, we are here. You know, we are one resource. We hope we are the resource for you. But also, there are many other agencies out there that are going to be able to help support you. And then, you know, building your support system. using your hospice teams, using your palliative care teams, using all of the consultants that you have at your fingertips to be able to help you as you move through this. And then also recognize and celebrate accomplishments. We know that staff, there are great staff in your communities that are doing this right, that are going to be able to model these behaviors and these changes for folks. And like I said, one step at a time, celebrate together. And we really hope that these steps that we've just outlined will get you excited. I mean, I think that this is something that is just good all around, that there's just so many benefits for your staff, for your families, for everyone. So we are here. Everything that we've talked about is available online. And again, remember I had mentioned some of those diagnostic toolkits are also available on our website. If you have curriculum that you're using and you would like that to be reviewed by the Alzheimer's Association, we can do that. If you don't have current curriculum, like I said, coming out this summer in 2020, we have new curriculums that are going to be available, exciting, that you'll be able to implement in your care communities. So I think I did it. I think I kept it to 30 minutes. So I'm going to, I guess, open it up for any questions for my section.
Yes, thank you, Jill. That was great information that you shared, and we are opening up for questions right now before we go into the second portion of the presentation. So I'm going to switch if you can bear with us for a moment, I'm going to change presenters over to Kellie. But in the meantime, if you can type in your questions, we're taking questions that Jill or Kellie or any of our Alzheimer's folks can address right now. Give it another minute. If there are no questions, we'll have Kellie go into her piece, but we'll give it another couple seconds here. We have a question. We are currently looking for a dementia care coordinator. Do you have any suggestions? That's a good question.
Wow. Geez, Kellie, you can also jump in too. I think one of the I don't know. That's a good question. I don't know. I would definitely look towards folks that have been active and maybe even certified in the certified dementia practitioner, that role.
And hopefully it's someone who has a good amount of experience, that maybe has dementia training, obviously has a lot of experience in dementia care. And I would also be looking for someone who's got experience and or training in person-centered care.
Right. And again, I think don't just hold tight to, that clinical staff. I've seen a lot of memory care units that I've been in that have a therapeutic rec staff that is their director. Even occupational therapists, I'm starting to see some OT folks that are really focusing on geriatrics. So maybe just kind of broadening your scope.
And I find a lot of the people that I've met in the professional care setting who do dementia-specific care, in addition to, training and education and background, I get a sense and a feeling from them that they really have compassion, a lot of compassion and patience with working with people with dementia. So, personality traits as well as professional background, I think are important to consider.
Great, thank you, ladies. Sarah, did you have anything else to add? I think Sarah is on the line. I didn't know if Sarah, you had anything you wanted to add to that, to answer that question. All right. I don't think Sarah has anything to add, and we don't have any other questions at this time, so we're going to go into Kellie's portion of the presentation.
Great. Can you see my screen, Wendy? Is it coming?
Yeah, looks good.
Okay, great. Well, welcome everyone, and thank you. We're going to jump right into the second half of our presentation today about understanding and responding to dementia-related behaviors. Some of the most difficult behaviors, most challenging behaviors for caregivers to understand and address typically start to arise in the middle and later stages of the disease. And it's important to keep in mind that as the person with dementia progresses into these middle and later stages, that they cannot control how they react to their environment. The disease process prevents them from being able to reason or logically use coping mechanisms like you or I would use to deal with pain or anxiety or fear. So that's important to remember. And if you take anything at all away from this portion of our presentation today, I hope you'll remember that all behavior has meaning, and all behavior is a form of communication. When someone is expressing a behavioral symptom, it's because they're trying to tell us something. They're trying to express a physical or emotional need. So behavioral changes can be caused by many things and have many what we call triggers. They can be caused by physical discomfort, pain, fatigue, hunger, thirst, constipation, having a full bladder that's uncomfortable. Maybe the room that they're in is maybe the temperature is uncomfortable, too hot, too cold. Behaviors can also be stimulated or triggered, triggered by overstimulation or boredom. Understimulation can be triggered by emotions like fear and sadness, frustration. Frustration often ties in with maybe the tasks that we're asking them to do are becoming more complicated for them as their abilities decrease over time. Maybe they're feeling isolated, or they've had a change in their routine or their living situation. And certainly we know that as the disease progresses, their surroundings, their environment becomes more unfamiliar. People become more unfamiliar. So all of these things and many more can trigger behavioral expression. So we're going to explore today how we can understand and address common dementia-related behaviors by using this four-step process that you see on your screen. The first step is to detect and connect. The second, to address physical needs. Then we address emotional needs. And then finally, we reassess and plan for future. So we're going to start with the first step, to detect and connect. The first step in understanding and addressing behaviors is really to be able to detect and connect by joining the person in his or her reality. And this goes back to that theme that Jill mentioned in the first half of our presentation about really implementing person-centered care. Because we really can't join a person in their reality if we don't understand where the person is coming from and what their reality is. And it's going to be different for every person with dementia. So I don't know if you've heard the saying that if you've met one person with dementia, you've met one person with dementia. Because dementia can manifest in different ways for every individual. So being able to connect with them in that first step and join their reality means how we can see the world through their eyes rather than our own. So if we remember that behavior is a form of communication, then we know that if we could actually see the world through the eyes of the person with dementia, and if we could try to experience what they experience in the way that they do, then the behavior would probably make sense. And since they're the ones that have the disease, we can't expect them to accommodate our needs. We have to enter their world. We have to connect with them where they are and do our best to decode or decipher what it is that they're trying to express and communicate. Sometimes it's very difficult. Sometimes we can't figure out where the behavior is coming from or what the person's trying to communicate. But it's really our job to make every attempt to understand what's going on before we intervene so that we know how to best help the person. So to understand the behavior, it really does take some detective work to try to determine what's triggering the behavior. So we use in the second bullet point here, in order to understand the reality, we really need to ask ourselves the who, what, where, when, and how. And that simply means the who is present when that behavior takes place. The behavior could be triggered by someone providing care. It can be triggered by a family member who's there to visit. It can be triggered by another resident. So who is present when the behavior is happening? What happened? What happened just before the behavior began? That may be a clue to what triggered the behavioral response. So what were you as a staff person doing before the behavior began? What was the resident or the person themselves doing before the behavior began? What happened immediately before the behavior takes place? When does the behavior, let me go back. Where? I skipped where there. Where did the behavior take place? Is it taking place in the resident's room? Is it taking place in the dining room, in the activity room? Where is the behavior happening? Was it something in the environment that is triggering the behavior? What was the person seeing or hearing or touching? What was going on and where did it happen? When does the behavior tend to occur? Is there a particular time of day that it takes place? Are you seeing the behavior in the morning or at mealtime or in the evening? So when is it taking place? And finally, how did you as the staff person or the caregiver, how did you react in the situation? What was your response? Because oftentimes behaviors are triggered by how we are responding and providing care. So how did we react to the situation? So in this process, while we're assessing through asking ourselves these questions, we also need to connect with the person. We need to make that initial connection. We need to approach them calmly, respectfully, maintaining their dignity. And that connect piece is really how we are validating the person in that moment of their reality, because we know with people with dementia that every moment can be different. So how are we approaching the person? That sometimes can trigger a behavior, literally how we approach them. Are we approaching them with respect? Are we treating them as they would like to be treated? Because despite how the disease progresses along the continuum, the person with dementia still maintains a sense of self. And so how are we approaching them? Are we coming to them? Are we approaching them from the front? Are we identifying ourselves? Are we making eye contact? Are we moving to the resident's physical level and using our eye contact and body language to convey a friendly approach? So what are they reading from our verbal and nonverbal interaction as when we approach them? Because the person with dementia will respond much more to our tone and body language even than our words and what we're actually saying. They get a lot of of what we call communication from us through the tone of our voice, the pitch, the loudness or softness, whether we sound like we're being friendly or happy versus being frustrated or angry with them. So our tone, the tone of our voice and our body language really tells them a lot and can affect how they interact and respond to us. So it's important to be kind and also be aware of your own body language and your own emotional state, in addition to what we're seeing from the person with dementia and what they are communicating to us. So the next step is to address physical needs first. So once we've made that connection, you know, that we've detected there's an issue, a behavioral issue, and we've made that connection, then we move into looking at, are there any physical needs first? Are there any, is there a medical condition? Is there any physical pain that the person may be experiencing? You know, and hopefully in terms of our understanding and knowing the person in that person-centered care model, we are sharing and we have updated and good information from, you know, the resident's physician and other members of the medical team to be able to identify causes that might be related to medications or illness or comorbid conditions. So are there any medical issues that we need to address or pain that we need to address? Other physical needs include, is the person hungry? Are they thirsty? What environmental triggers might be causing discomfort? Are there any signs of injury due to a recent fall? People with Alzheimer's disease often experience pain from things that maybe aren't outwardly physically evident. So they may be experiencing pain from an undiagnosed urinary tract infection. They may have compression fractures, arthritis. Maybe their dentures are poor fitting or not in place properly. Maybe they're having indigestion, they're having constipation. You know, it's not always easy to see these signs outwardly, but it's important to evaluate the physical and medical needs first. As far as medical issues, another trigger for behavior or a behavioral change may be due to the reaction to a new medication or an interaction between multiple medications. So that's another thing to look at. So, you know, the physical and medical needs may not be easily recognizable. And oftentimes, you know, again, as the person is progressing through middle and later stages, the person themselves may not be able to really recognize or process what they're experiencing or be able to verbally talk about it or express it. So, you know, making note of any unusual behaviors or symptoms and making sure that if we think it's a medical or physical need, that it's being reported to the medical team so that we can at least either treat or rule out that there's a medical issue or pain happening. We can also check for physical discomfort due to environmental issues. So maybe the clothing that the person is wearing is restrictive or not fitting properly or not put on properly. Maybe there's lighting problems in the environment that are causing problems for the person visually or maybe causing glare or shadows. Is, again, as I mentioned earlier, is there an uncomfortable room temperature for the person? So that may be happening. Additional common causes of discomfort include hunger and thirst, the need to stretch or move, the need to use the bathroom, the room being too bright or too dark, too noisy, too quiet. Maybe they're sitting in an uncomfortable position. Maybe the environment is just too overwhelming in that moment. There's too much commotion and noise and activity going on for them to handle or process. So in addition to physical pain or a medical issue, There may, maybe we need to make an adjustment in the environment, or maybe move the person to a different environment to be more comfortable. So all of those things play into the second step of really addressing the physical needs first. Once we've done that evaluation and ruled out anything in that category, then we can move on to looking at, does the person have an emotional need that is triggering the behavior? So we as the caregivers need to think about how the situation in that moment feels to the person. This can sometimes be the basis for their behavioral reaction. So in that way, we need to focus on the person's feelings, not necessarily on the facts of the situation. We need to try to decipher what emotions might the person be feeling that are causing them to act the way they're acting or say what they're saying. So they may not be able to properly express themselves if they still are verbal. What they're saying may not be a true indication of what they're feeling. And that's just an effect of the disease. Again, they have little control as time goes on, and they decline in being able to express themselves. So we really want to try to get to the emotional need, the underlying emotional need. One thing that we should try to do is try to avoid correcting people if what they're saying isn't accurate. Because we're trying to connect with them where they are. So what they may say may not be making sense for the situation. And we certainly want to avoid correcting or making them feel like they're wrong, because that's only going to escalate the situation. And it's also in that attempt to connect with them, if we correct them or make them feel like they're doing something wrong, that's also going to convey that we're not understanding them. And that doesn't help with making the connection and building the trust with them, the trust that you can help them. So we want to try to avoid that. The person will actually try harder to convince you, and that may make them more upset. So we want to be careful with how we approach them. We want to let the person know that we're with them, we care about them, we want to help them, and that they're safe. And we want to reinforce that we're there to help, and we will try to do whatever we can to make them more comfortable. Although we may not understand the exact meaning of what they're trying to express, we can usually identify the feeling behind the behavior and be able to address the emotion behind the behavior to help the person feel less overwhelmed, feel less alone. It allows both the caregiver and the person with dementia to be able to de-escalate the situation together, and be able to direct energy and attention elsewhere. We talk a lot about redirection when it comes to responding to behaviors. So being able to initially, take a step toward de-escalating the situation can help us to move forward, to help both people to move forward. And then finally, as I mentioned, trying to redirect the attention and the energy that the person is expressing through the behavior by leading them toward something, an environment or an activity that is more soothing and enjoyable. And then finally, the last step is to reassess how we responded to the behavior and whether or not it de-escalated or escalated. So we need to go back to that step of, did we properly detect the trigger for the behavior? Were we able to connect with that person and join their reality? What went well in the outcome of that response? What didn't go well? Because what went well, we know we can employ next time that it might happen, and what didn't go well, we may need to make changes or adjustments. So certainly after we assess and resolve a situation, we want to go back and reassess it so that we can plan for the next time it happens, because we know that when behaviors start to manifest and begin expressing, we know that they will likely happen again. And many behaviors are repetitive. So how do we reassess and plan for future? So let's look at applying this 4-step process to some common behaviors that we see. And these steps can really be applied to any behavior experienced by someone with dementia. And it's important to keep in mind when we talk about that 3rd step of really trying to detect and identify an underlying emotional reaction to something in the environment. Keep in mind that a lot of behavioral symptoms in dementia are triggered by some fairly common emotions. Certainly pain or physical discomfort is one of the more common triggers. Fear is a common trigger, because remember, for the person with dementia, as they're progressing through the disease, their environment, the people in their environment, the things in their environment, day by day, week by week, month by month, are becoming more and more unfamiliar. And that leads to fear. That fear can also be coupled with a sense of insecurity, of not feeling safe. So we often find that a lot of our responses to behavioral symptoms have to include being able to reassure the person and make them feel safe. So this first common behavior that we're going to look at, for sake of example, is anxiety or agitation, which is a very common behavior for people with dementia. When someone with dementia is restless, or they start to pace, or they seem distressed, or maybe they're becoming excessively reliant on their caregivers and shadowing, and feeling a constant need to be close to or connected to a caregiver, it may be a sign that they're experiencing some increased anxiety and agitation. So let's say, for sake of example, a scenario that we have Anne, who's a 75-year-old woman with Alzheimer's disease, and the behavior that she's expressing is that she's pacing the hallways in the evenings, excessively pacing. And while she's pacing, she's saying, I need to go, I need to go. She won't stop walking, even for meals or even to eat. So staff may be trying to give her sandwiches to eat while she's walking, or finger foods that she can eat while she's walking. And even though she uses a cane, maybe she's getting blisters on her feet. And now we notice she's losing weight because she's not eating enough while she's pacing. We may ask her to sit down, but as soon as she sits, she gets right back up again and she starts pacing again. So in a person-centered care model, if we really know our resident Anne, maybe we know that for 40 years, Anne worked as a nurse on the night shift. And we see that her agitation and her anxiety or the behavior that she's expressing is happening in the evenings. Her shoes are getting worn. Maybe it seems like she's in pain as she's walking, because again, she's pacing so much that maybe she's getting blisters. So in that scenario, there's a lot of things going on for Anne. Maybe it's when we go through that 4-step process, what if any are the medical or physical needs? She's walking a lot. She's getting blisters. She might have pain in her feet from all the walking. And she in the disease can't connect that the excessive pacing is what's causing the pain. So she can't process that to be able to make a change herself in her own behavior. So maybe there are some medical and physical needs. There's also an emotional need in that scenario, and a preference and a lifestyle and a routine that is prevalent in Anne's reality. Again, she may not, you know, have been a nurse for the past 10, 20 years at her age, but she did spend 40 years as a nurse working the night shift. So in Anne's reality, she may be living back in that time period, because we know for the person with dementia that as time goes on and they progress, their mind regresses, their reality regresses. So they're not living in the present. She may be living in the past. So for Anne, at that time of the evening, when she starts to pace, she feels she needs to be at work. She's a nurse. She works the night shift. She needs to go. It's similar with individuals who start to pace and want to exit at, you know, late in the afternoon. Sometimes later afternoon and evening time of day, when we see behaviors at that time of the day, that's a very transitional time in life, no matter where we are in our stage of life. Late afternoon, early evening is a very transitional time. It may be transitional in your community environment. Shifts may be changing. New people are coming in, first shift is leaving. So there's a transition in the environment itself with your staff. It's also can be a transitional time in the mind of the person with dementia. They need to go, for Anne, maybe she needs to go to work. That's what she's experiencing. Maybe for someone else at that time of the day, they need to get their kids off the bus. Their spouse is coming home from work. They need to start dinner. So it's a very transitional time of day that can cause behaviors to be triggered. Sundowning, as many of you I'm sure are familiar with, can cause that in a late time of day. People who are present in the room. Again, this is working through that 4-step process, the who, what, when, where, and how. Maybe there's people present in the room that are causing the anxiety or the agitation. Maybe, you know, an activity or a task or an ADL that we're trying to do with the person is becoming too complex now as their abilities decline, and they're becoming frustrated because they can't complete a task. You know, and we need to adjust how much assistance we provide in those situations. Again, pain, infection, UTI, is something upsetting happening in the environment? How do we comfort them and distract or redirect? So I'm sorry, I've just talked through these 4 steps without changing the slide, but we will move on. So another very challenging behavior, hopefully not quite as common for you in your settings, but certainly a challenging behavior is aggression. And sometimes a person with Alzheimer's can experience aggressive behavior. The aggression may be verbal, it may be physical, it may be both. There may be a trigger that we can identify for that aggression, and then there are times when aggression may seem to appear for no reason. But aggression certainly, we need to keep aggression from escalating, you know, and because that presents a safety issue, not only for the person with dementia, but also for caregivers or you know, neighboring residents in the environment. With aggression, again, being able to put ourselves in the person's reality, it's okay for caregivers and staff providing care to apologize to the person and be apologetic if we think it will help to calm the person, or if we have evidence that it can calm the person. It's okay to apologize. We may be apologizing for something we feel we didn't do, but we have to remember that the apology we're offering is a reflection of the person's reality, not necessarily our true reality. So it's okay to apologize. So if we're working through, again, that 4-step process, are there any physical or medical issues that may be causing the aggression? Because sometimes people with dementia might lash out when they are in pain. If they can't tell you they're in pain, if they can't process and identify exactly where the pain is coming from, they're just feeling extreme pain, then they may physically lash out because of pain. We can screen the environment for any obvious triggers. Is there aggressive behavior being caused by excessive noise? The noise may not be excessive to us, but to the person with dementia, it may be too excessive. Are there changes in their usual routine? Is there a sudden change in their usual routine for some reason, or their schedule? Is there something or a person in the environment that they perceive as a threat, which would cause them to act aggressively or in self-defense? One of the key things to keep in mind with aggression is that we really need to make sure that everyone involved is protected so that no one's getting hurt. So if there's children in the room, we may need to remove children from the room. So it's hopefully this aggressive behavior doesn't escalate to that point, but we really do need to be cognitive of safety in aggressive situations. Beyond physical and medical needs, are there any emotional needs that can be triggering the aggression? People can act aggressively when they perceive danger. If they feel threatened, they're scared, they're surprised or alarmed, those things can trigger aggressive behavior. We call it aggressive behavior, but for the person with dementia, it may simply be an expression of self-defense. So we have to take that into consideration. And I'll give you an example. We had a situation one time locally with a male resident who had become aggressive, where he was hitting and biting. So it was physical aggression toward the staff in a residential setting. And when the staff stepped back and went through this process of assessing the situation and looking at what might be triggering the behavior, they looked for, there was definitely a pattern to the behavior. And what they were able to, the pattern that they were able to assess was that the aggressive behavior was always happening in the evening and overnight during third shift. So the resident wasn't being aggressive in the morning, at noontime, during most of the day, but the aggression tended to happen only in the evening and during the third shift. And not only the staff in the community, but when they brought the family in and also included the family in that team assessment, they discovered, what they learned from the family was that the staff person who was providing care during that shift, that evening shift, actually reminded the resident of someone who bullied him as a child. And so it had nothing, it really didn't have anything to do, or it wasn't a reflection of the quality of care or that caregiver as a person. It's just that, again, in the resident's reality, they perceived that the staff person was a bully, and their aggressive behavior was a form of self-defense. And so the resolution that the staff came to was, we need to have a different caregiver providing care for that resident on that shift. So that's kind of how they worked through that process. So aggressive behaviors are not always dangerous. They're certainly very challenging and very upsetting, but they're not always dangerous. But we do need to be able to evaluate if the person or the behavior poses a danger to the person with dementia, to the caregiver trying to provide care, or to anyone else in the environment, whether it be visitors or other residents. So, there are occasions for aggressive behavior where safety measures, I'm sure, in your communities are in place and may need to be implemented. Also, certainly if aggressive behavior is frequent and consistent, and we're not finding ways to non-pharmacologically resolve it, then, we may need to consult the physician or the medical team about medical interventions. And certainly, I'm sure you all have protocols in place for having to use 911, if a situation is urgent. So the last common behavior we're going to look at in the interest of time today is wandering, which certainly is very common, very unpredictable. Wandering can happen without any warning. Most times it's not necessarily dangerous, and certainly not as dangerous or not as much of a safety issue in a secured community environment. But the percentage of people with dementia who will wander, of course, is very high. So at some point in the course of the disease, 60% of people with Alzheimer's or other forms of dementia will wander. And usually with wandering is oftentimes a repetitive behavior. So once it starts, it will likely happen again. So we need to be prepared to address it. There are many things that can trigger wandering. Oftentimes it's because the environment has become more unfamiliar to the person. They don't feel like they're home. They don't feel comfortable in the environment or the room that they're in. So they seek to remove themselves from it. It could be that the environment is overstimulating and they need to get away from the noise or the activity. People can wander because they're bored and we're not engaging them enough. They're understimulated, may lead to pacing and then wandering. And they may begin to wander because they're looking for something. Maybe they need, when we're addressing those physical needs, those medical needs, maybe they need to use the restroom. And they're at a point in the disease where they're so disoriented that they really can't find the restroom. Or maybe they're hungry, and they start to pace and then go off wandering because they're looking for food or a restroom. So there are many things that can trigger wandering. Maybe again, a person in the room is making them uncomfortable, whether it be a family member or a staff member or a visitor. Can make somebody feel uncomfortable to the point that they may wander because they want to leave the room. They want to leave that environment. So, again, we address the physical needs first. Is there any pain? Is there a medical or pain issue for that person? Because wandering can sometimes begin if the person with dementia is trying to move away from pain. So again, they can't process or reason through situations like we do. So when they feel pain, they want to get away from it, in a sense. So are they trying to move away or escape from pain? Are they reacting to a change in the environment, difficulty with something in their immediate surroundings? Have there been any changes in their pattern of exercise or daily routine lately? I mentioned, are they responding to an unmet need? Are they hungry? Are they thirsty? Do they need to go to the bathroom? All of these things can trigger wandering. What are the emotional needs? I mentioned boredom, being understimulated. And it's okay as a caregiver when we're addressing the person and trying to connect with them, it's okay to identify and validate their feelings in that connection stage. We can approach the person and we can respond to them and address them by saying something like, you seem sad, you look scared. That validates their feelings, that emotion that they're feeling in that moment. And when we validate that emotion, we connect with them and they have a feeling that we understand what they're feeling, and that builds trust. So it's okay to verbally express that to them. In most cases, if we can provide reassurance that they're safe and you're there with them to keep them safe, that can help. And maybe in the case of wandering, can we help the person do what it is they want to do through that expression of wandering? Maybe they're wandering because they want to go outside. Do you have a safe outdoor space? Can you grab your coat and take them outside for a walk? It's something they need to do. So, and hopefully, I'm sure in all of your communities, residential communities, you have opportunities to provide safe wandering. So maybe we just need to go with them, in that moment. Communication is a big piece of responding to behaviors. Communication can be verbal and nonverbal, and it's a two-way street. So we're not only reacting to how the person with dementia is trying to communicate with us, but we're also telling them a lot about how we are talking to them. The tone of our voice, our nonverbal body language can affect an interaction. And of course, communication happens in all stages of the disease. It's important, the highlight points of this presentation are important to remember to join the person's reality in order to connect with them, understand and accept what we can't change and what we can, knowing the difference, and remembering that that person is retaining a sense of self. So being able to react with them and engage with them in ways that maintain their respect and dignity is important in how they feel and respond to us. So I will stop there because I know we're getting short on time, and see, Wendy, if there are any questions. We could certainly talk about behaviors all day, but it's, hopefully they, the listeners got a lot out of that quick 30-minute overview.
Great. Thank you, Kellie. We will open up now for questions. If anyone has questions, please type them in the questions pane on the right hand of your screen. Again, while we're waiting for questions to come in, I will be sending an email later today with a link to the handout and also to the recording and the survey. So please take a moment to complete the survey that I'll be sending out later today. So keep an eye out for that. And also just check our website. We do have some more webinars coming up later this month and early next month in December. We have a Psychology of Change webinar coming up on November 26th, and the latest on medical marijuana on December 3rd. So we have those, and we're planning. We have a plan that we are putting into place for early 2020. And again, this survey gives you an opportunity to list any topics that you would like to see covered in future webinars. So not seeing any questions, I will also provide Kellie and Jill's contact information for you so that you can get in touch with them if you do have questions moving forward. And we do have a question that's come in. To set up a presentation to staff, to the community staff, who do I need to reach out to? This particular community is located in Chester County.
Well, certainly the Chester County is in the territory of our Delaware Valley chapter. So I would say that anyone in our region can certainly reach out to myself and or Jill.
Okay. Great.
And I know you just said you were going to provide that contact information, so you can certainly. I
will provide your contact information to everyone. And do you have any presentations for family caregivers?
Absolutely, we do. Certainly a lot of what we do is geared to family members. So yes, we do. And we, consistently throughout the year are fulfilling requests for communities that would like us to come in and be able to do educational free, and they're free to present educational programs for residents and family members.
There's a question that says, will you come to a community to do one? I believe for the family caregivers.
Yes.
Great. It's a great resource. Yeah, I think it's probably underutilized if I had to guess.
Absolutely. We are always happy. And like I said, our programs are free to deliver. There's no cost. Typically the communities, if they're going, in fact, I just did one last night. Typically, if the communities are going to schedule and promote a free educational workshop for family members, they typically will open it up to the community. And really, if there's any cost involved to the community, it's just in providing, maybe snacks and beverages if they choose to. But there's no cost for the presentation.
Great, thank you.
And there's certainly no cost for the community or family members to attend.
Wonderful. Yeah, great resource that's available. Okay, not seeing any more questions. I will wrap this up. Again, don't forget to take care of your survey, respond with that. It is helpful to us and to our speakers. Thank you again to Jill and Kellie for presenting today. It was a lot of great information, a lot of good resources available to you. And everybody have a great remainder to your day.
Thank you, Wendy, and thank you for everybody who joined in.